Dear all, good evening. We are from ANBAI office. We will start this in the next 2 minutes. Thank you for your patience.
Good evening all. Good evening all. Welcome to the ANBAI series of lectures on applied basic sciences. It is a warm welcome for me and to you all. Amidst this COVID season, we are meeting up for this academics, and I hope this will be very useful for you. It takes me my pleasure to introduce our today's speaker, Dr. Rangarajan Kasturi. He is the senior consultant in Department of Gastroenterology in Narayana Hrudayalaya, Bangalore. So he will be talking about the liver function test and its interpretation and the usefulness in our day-to-day practice. So hope it will be useful for you all. The only request is kindly cut off your audio and please listen to it, and whatever questions you have, you can put it into the chat box and we can discuss it further. So over to you, Dr. Rangarajan. Please take over.
Thank you, Dr. Srinath, for the warm introduction, and thanks to Dr. Muralidhar and ANBAI for giving me this opportunity to present this chat. I'll start sharing my screen. Can everybody see my screen?
Yes, sir, we can.
Okay, good, good. So this is going to be a basic talk about liver function tests and interpretation, and I'm trying to keep it basic and simple, and there will be a few complicated things in between as well. But I think the idea is just to get the basics through in this next hour or so. So what I'm going to talk about first is about what we call about a liver function test, or what is the new term liver biochemistry test, because the test actually doesn't talk about the function when you look at the panel, and I'll explain why. There are tests that we can use to look at liver synthetic function, i.e. the albumin and INR, which we'll touch upon. And then we'll look at an approach to recognize different patterns of abnormalities in the liver biochemistry and look at how we approach it clinically. And then there are a few concepts of liver fibrosis, which is scarring in the liver. And there are tests now available for detecting early fibrosis, and we'll touch briefly on that. And then a brief mention of scoring systems for prognosticating people with chronic liver disease. And if time permits, I'll show a few case examples which we have encountered in our day-to-day practice. So what are liver function tests? So basically, if you look at a liver function test report, the first thing that will come is bilirubin. And within bilirubin, they usually give you a total and a direct, and some labs will give you an indirect. And there is also the next set of tests, which is ALT and AST. These are called the aminotransferases now. Previously, they were called transaminases. And the old terminology for ALT was SGPT, and for AST was SGOT. The alanine transaminase, which is ALT, is an important enzyme for the liver, and I'll explain why in the next few slides. Alkaline phosphatase and gamma GT are other two important components of liver function test. And within the fine print, you'll find a test called 5-nucleotidase, which is not commonly used, but can be a useful test in situations where we are stuck in differentiating between a cholestatic pattern and a non-hepatic source of alkaline phosphatase. So I'll just add a few words on that. So we'll start with bilirubin metabolism. So we'll just start with the basics. So just to bring my pointer, so bilirubin, as we know, is formed from the blood cells. So you got hemoglobin, which when the cells break down at the end of their lifespan, is broken by the reticular within the reticular endothelial system into heme and globin, and heme is further oxygenated to biliverdin and then to bilirubin. So bilirubin is formed in the reticular endothelial cells. Now this bilirubin has to be excreted and reutilized. So what happens is bilirubin that's formed in the reticular endothelial cells is not water soluble. So it binds to albumin protein, and then it's transported through the portal system to the liver. Within the hepatocyte, there is a reaction called conjugation. Okay, this is catalyzed by an enzyme called UDP glucuronyl transferase, and basically the bilirubin is combined with glucuronic acid to give bilirubin diglucuronide, which is water soluble. So making it water soluble makes it easier for it to be combined in bile and excreted out into the intestine. Within the intestine, the bile performs an important function of micellization of the fats and helps in digestion. And once the bile reaches the distal intestine and the large bowel, there is a formation of urobilinogen from the bilirubin because of bacterial action, and some of it goes through the stool as stercobilin, and some of it is reabsorbed by the enterohepatic circulation and reutilized by the liver, and some of it goes through to the kidney and is excreted as urobilin. So there is a complex pathway, and the breakdown in various parts of the pathway can cause hyperbilirubinemia. So how do we measure bilirubin in the lab? So there is a reaction called van den Berg reaction, which incidentally was described almost 100 years ago in 1921. And so what happens is that there is a process called dietization to which the serum is subjected to with sulfonylurea acid, and the conjugated fraction of the bilirubin reacts promptly within 10 to 20 minutes, and you get reading which you can read called the direct bilirubin. And then they add an accelerant, which is alcohol or caffeine, and then after about 30 minutes the second measurement is done, and this by spectroscopy, and this gives the total bilirubin. So we can measure through Vandenberg reaction the direct bilirubin and the total bilirubin, and to get the indirect component of bilirubin you have to subtract the total and the direct. There is also a bilirubin called delta bilirubin, which sometimes is encountered in people with profound jaundice, and this is bilirubin that's covalently bound to albumin. So this bilirubin cannot be conjugated and it cannot be excreted, and therefore this bilirubin stays in the system for the life of that albumin that it's bound to, so for about 2 to 3 weeks. And this explains in some patients why it takes longer for the bilirubin to go down despite the enzymes coming down a lot earlier, especially in some patients who have prolonged hyperbilirubinemia and don't have bilirubinuria. And the next important part of the LFT are the aminotransferases. Aminotransferases, the ALT and the AST, are very important enzymes for us to assess the liver function. And ALT is primarily present in the liver and therefore is more specific marker of hepatocellular injury. It is present in the cytoplasm and it helps in transferring alanine moiety to the pentose ring. The normal value as per studies, these are from American subjects, is about 29 to 33 for males and 19 to 23 for females. But within practice, I think we accept up to 40 as being normal. And then the other enzyme that we look at is the AST, aspartate transaminase, and it's present in the liver. But the problem with AST is that it's also present in other organs, mainly cardiac muscle, skeletal muscle, kidneys, and the brain. So the problem with raised AST is that it could rise due to injury to the heart. It's in a myocardial infarction. It can go up when somebody has a skeletal injury or even an intramuscular injection. So sometimes AST being raised alone may not be hepatocellular in origin. So that has to be combined with the ALT and the other enzymes to draw the inference that this is hepatic related rise in AST. So the readings again is roughly about 40 units for male is the upper limit of normal and 32 units for female, and sometimes there will be slight variations because of local reference values in the labs. The next enzyme we look at is alkaline phosphatase, which is a group of isoenzymes which are widely distributed throughout the body. So the main sources are liver and bone, but also you can see them in placenta, small intestine, and also the kidneys. In the liver, alkaline phosphatase is found on the canalicular surface, and it can be a marker of cholestasis, so that impaired excretion of bilirubin, which we describe as cholestasis. And the normal range, again, depending on the reference ranges, can vary, and there are a couple of ways that it can be measured. So the usual now the present range we get is roughly around 120 being normal. Gamma glutamyl transferase is another enzyme that is sensitive for the liver, but it's not specific. So it has always got to be read along with the phosphatase. So if alkaline phosphatase is raised and the gamma glutamyl transferase is raised, then you can infer that there is cholestasis. But if the gamma GT is raised by itself, there can be many reasons, and the commonest reason is alcohol abuse. So whenever somebody is drinking a consistent amount of alcohol for a few days, the gamma GT rises. It can be used as a surrogate marker of abstinence sometimes, but it's not usually done so. But in clinical practice, if you see somebody who's claiming abstinence, but you see a raised gamma GT, you can always question whether that's really true. Gamma GT can go up in other disorders as well, like pancreatic disorders, myocardial infarction, renal failure, COPD, and certain drugs. And like I said, it should be interpreted in relation with alkaline phosphatase. And if there is a cholestatic pattern, then as we will discuss later, there is a specific pathway for investigating that. But gamma GT rise by itself may not require an exhaustive investigation, because by itself it may not have any clinical significance. And a quick word about 5-nucleotidase. This is another enzyme that's present in the liver, but also in multiple organs. But primarily, the serum 5-nucleotidase levels come from the liver. And when we are stuck with a raised alkaline phosphatase and we are not sure whether it is liver origin, this may give us additional information. It's not commonly done though. The next part will talk about the synthetic function of the liver. The synthetic function is where the liver has some important synthetic activity in terms of maintaining clotting and in terms of maintaining plasma oncotic pressure. So in terms of clotting, the liver produces most of the factors except factor 8, which comes from the endothelium, the anti-hemophilia factor. But most of the other factors are produced in the liver, and the vitamin K dependent factors 2, 5, 7, and 10 are those that determine the INR. So INR has prognostic value in patients with multiple liver disorders. For instance, in acute liver failure due to paracetamol, and also in non-paracetamol acute liver failure, and in alcoholic hepatitis. So it does have prognostic value, and even in following up patients with chronic liver disease using MELD score, INR is one of the important components of the score. The important concept that's recently emerging is that whenever we see high INR, we think patient is going to bleed because we always associate INR with clotting. And prothrombin time is not an accurate measurement of bleeding risk in patients with cirrhosis. And the reason for that is that there is a component at the same time as the INR raises, there is a fall in protein C, protein S, and antithrombin 3, which are the factors which are procoagulant within us. So which are natural anticoagulants, which are natural anticoagulants and makes somebody tend to become procoagulative. So the lack of protein C, protein S may be a factor why there is a rebalance in hemostasis, and this is reflected in decreased synthesis of 2, 5, 7, and 10. This is the recent hypothesis. So sometimes we have to look beyond INR and use a test called a thromboelastogram to accurately measure the clotting in patients with liver disease, specifically when they are bleeding and we don't know which component to replace, blood component to replace, or before doing surgery for these patients. A thromboelastogram might say that the clotting is actually balanced and normal when actually the INR may be raised. So there are tests beyond the INR which are helpful in clinical practice, but these are done in specific situations. So the other synthetic function that the liver does is synthesis of albumin, which is an important protein in the body for maintaining the oncotic pressure and carrying the various unbound plasma molecules in the plasma. And generally, at any point in time, normal adult will have 300 to 500 grams of plasma distributed in the body. And about 15 grams per day is produced, and there is a loss of albumin through kidneys and few other sources from breakdown, and 15 grams is produced to replace that, and half-life is 14 to 21 days. And 70%, approximately 70% of the plasma oncotic pressure, which helps us keep the fluid in the intravascular space, is maintained by albumin. So that's why in hypoalbuminic states we see anasarca. And hyperbilirubinemia may also be a reflector of other disorders. So while hepatocellular dysfunction is what we are focusing on, there is also loss of albumin like in nephrotic syndrome, protein losing enteropathy, and also in systemic inflammatory conditions. Malnutrition, chronic malnutrition may also show hyperalbuminemia, but albumin by itself is not thought to be a great marker for malnutrition. Sepsis, again, in a systemic inflammatory response, in an acute inflammatory state, in various situations like patients who come critically ill in ICU, albumin may be low, and this is a reflection of the systemic inflammation rather than synthesis. Next, we look at patterns. We start looking at patterns of abnormalities in the liver function test. So, what are the patterns we encounter? We try to classify them according to the way we need to investigate and manage these patients. So the first pattern we look at is something called isolated hyperbilirubinemia. In this pattern, you have patients presenting with maybe a mild jaundice, and they have a raised bilirubin on their liver function test, but the enzymes tend to be normal, and any imaging that we may do, maybe an ultrasound, may also be normal. And these patients may have secondary disorders, which I'll explain in a bit. other comorbidities which may be responsible for hyperbilirubinemia. So isolated hyperbilirubinemia, initially we focus on disorders of bilirubin and then a few conditions where it's secondarily raised. Then there is the hepatocellular hepatic pattern. This is a pattern which we see in patients who have an acute liver injury or a chronic liver injury. So the pattern is that where we see there is an increased ALT and increased AST, and usually the classic hepatocellular pattern should have a normal alkaline phosphatase and a gamma GT, but there may be some rise in these enzymes as well, and I'll explain how to distinguish. The second pattern we see is called cholestatic. And the cholestatic pattern is where there is an impaired excretion of bile, and therefore the bilirubin rises. And you have raised alkaline phosphatase and gamma GT or a 5-NT as a marker of cholestasis. These patients typically will have a normal AST or ALT, but again they may be raised in certain conditions. And bilirubin can be raised or may not be raised and may come late in somebody with hepatitis. So there can be a variation in bilirubin. And then we can classify the patterns into acute, subacute, or chronic based on the temporal presence. So when we have somebody who has got rise in liver enzymes and we are confused, AST, ALT is raised, alpha gamma GT may be raised, and suddenly we are thinking, is this cholestasis or is this hepatitis? So because the reason we need to know is that the investigations and managements vary between the two conditions. And so there is a value that's been derived called the R value. So the R value helps us to distinguish the patterns. So what you need to do is divide the ALT by the upper limit of normal of the ALT for that particular lab, and the measured alkaline phosphatase divided by the upper limit of alkaline phosphatase, and take a ratio of these two results. So if you get to give you an example, if somebody has an ALT of 500 and the upper limit of normal is 50, or for that particular lab, the ALT ratio will come as 10. And then the alkaline phosphatase, if somebody has a reading of say 200 and the upper limit is 100, it will come as 2, and 5 divided by 2 will give you the R value. And if you look at that, then you can try to work out whether it's a mixed pattern or whether it is a hepatocellular pattern or a cholestatic pattern. Typically, hepatocellular pattern will give you R value of greater than 5. And if you get a 2 to 5, then you call it a mixed pattern where there may be an overlap between both cholestasis and hepatitis. And then below 2 is usually a pure cholestatic pattern. So understanding the pure hepatocellular and pure cholestatic pattern may help us to direct the investigation. So what do we do when we get a patient with abnormal LFT? So what is the clinical approach? I think as in anything else, we start with a detailed history. So the history should focus on the history of jaundice if there is a presentation with jaundice, the onset, the duration, and any associated symptoms. For instance, somebody having what's called the Charcot triad, which is right upper quadrant pain and fever with chills, may have cholangitis, ascending cholangitis. And then there is an addition of shock and altered sensorium to Charcot's, which gives you what's called a Reynolds pentode. Both of them are specific for ascending cholangitis, though the sensitivity is pretty low because there are a lot of patients with ascending cholangitis who may not have all these features. Then there are features like weight loss, pruritus, and steatorrhea, which may suggest an obstruction and more sinister process as a cause for the abnormality in liver function test. Alcohol is an important history to take because vast majority of liver disease we see is related to alcohol. And then drug history is pretty important because I think you need to go back in time for a few months sometimes for certain drugs give a cholestatic picture even months after exposure. So they may have prescription drugs, over-the-counter drugs, complementary and alternate medicine drugs, and also illicit drugs. And IV drug abuse may be a reason for developing viral hepatitis. So it's an important history to take, and it's important to spend some time looking through all the previous prescriptions and trying to understand if there has been a trigger, because it will save a lot of trouble later on. And then there are other things to look for viral hepatitis. There can be high risk behavior in terms of sexual exposure, in terms of IV drug abuse. Travel and eating out may predispose somebody to the orophycally transmitted viral hepatitis like A and E. And then transfusions may expose somebody to problems like hepatitis B and C. And other comorbidities may also matter, because somebody with significant heart failure may develop hepatic congestion and thereby develop jaundice. So it's important to look at the person as a whole, look at whether they've had heart failure, whether they have obesity and diabetes, which may trigger, make you think that they have NAFLD, and then whether they've had a bone marrow transplant, which may start making you think whether there are things beyond the liver that may be responsible. And then pregnant women may develop various abnormalities of liver function tests, like cholestasis of pregnancy, HELP syndrome, and acute fatty liver of pregnancy. And also they are predisposed to having gallstones. So pregnancy is an important event, and the history must be taken accordingly. And then there are other disorders like autoimmune disorders, celiac disease, and thyroid disorders, which may also cause rise in transaminases. So I think that the history has to be detailed, and time has to be spent on the history. And that's very important when you're trying to interpret an LFT. So, and it's also important to examine the patient, and there are certain things that you can look for, which we call the stigmata of chronic liver disease. And generally, you may find icterus. There may be fever in patients with cholangitis and sometimes with viral hepatitis. There may be paucity of body hair. There may be signs of chronic liver disease like parotid enlargement, spider nevi, gynecomastia, and then you always look for hepatosplenomegaly. And then in the hands, there may be clubbing, palmar erythema, Dupuytren's. And then there are other things like xanthelismas and xanthomas, which may suggest a metabolic disorder. Hello? And there may be decompensation, where they may develop encephalopathy in the form of either coma or asterixis. And you always look for ascites and signs of portal hypertension in the form of dilated veins in the abdomen, like called caput medusae. And edema may signify a hypoalbuminemic state. So there are a lot of things to examine, and a detailed examination must be done at the bedside after taking a detailed history. So the patterns which we talk about, so we try to look at diagnosing problems, and then we are looking at the patterns. The first pattern we are looking at is called isolated hyperbilirubinemia, which we can divide into direct and indirect depending on the predominant bilirubin. So these are patients who may have present with jaundice, may have normal liver imaging, no comorbidities to account for the bilirubin rise, or they may have some other disorders. So when we talk about hyperbilirubinemia, so there are three categories. There is one, there is overproduction. Two, there is impaired uptake within the hepatocytes. And third, there may be a problem with the genes, genetic disorders, which I will explain in the next slide. So in terms of overproduction, you're looking at the breakdown of red cells in the reticuloendothelial system as the first process in formation of bilirubin. And so hemolysis, so hemolytic conditions which can be either inherited or acquired, like G6PD deficiency, sickle cell, spherocytosis, erythrocytosis, etc., or acquired causes like hypersplenism, paroxysmal nocturnal hemoglobinuria, autoimmune hemolytic anemia, and the hemolysis, intravascular and microangiopathic hemolysis, may all contribute to a hyperbilirubinemia. So the pattern in this is indirect or unconjugated. So basically, there is too much bilirubin in the system, more than what can be bound to the albumin and sent to the liver, and more than what can be processed by the liver. So once you identify this pattern, the key thing is to look at what your what is the underlying cause. So your investigations go down a hematological pathway rather than go down the route of imaging and doing further tests for the liver. So I think identifying indirect hyperbilirubinemia and hemolysis is important. Then again, ineffective erythropoiesis may be a simple explanation. Ineffective erythropoiesis again causes more production of hemoglobin from the bone marrow itself, and the consequent hyperbilirubinemia. And in ineffective erythropoiesis states like B12 deficiency, folate deficiency, and sometimes in severe iron deficiency and thalassemias, the treatment is totally different to what you would do with other conditions. So I think it's important to do blood films and LDH in these conditions, and measuring serum levels of B12, folate, etc., which may give you an idea about the cause. So once you have an indirect hyperbilirubinemia, so it may be hemolytic or ineffective erythropoiesis, and you are trying to find out what the cause could be using hematological tests. Then there is drugs. Like I said, the detailed drug history is important. And rifampicin is a commonly used drug for tuberculosis, and you see a lot of ATT-related drug-induced liver injury. So rifampicin causes impaired uptake, and it causes an indirect hyperbilirubinemia. So the other things that are rarely implicated are things like somebody having a large hematoma after a massive after significant trauma, and after having a massive transfusion. Sometimes you see transient rise in indirect bilirubin. And then there is the conjugation defects which lead to indirect hyperbilirubinemia, which are inherited. There is Gilbert syndrome, which is very common, almost found in 10% of occasions, and we see that commonly in India as well. And there is a genetic mutation which interferes with the conjugation of bilirubin. So you have a reduced enzyme of UDP glucuronidase transferase, so that activity is reduced to almost 30%. Because of which, whenever there's a stressful situation like say fever, fasting, etc., the bilirubin may rise, and the patient usually gives a history of fluctuating rise in bilirubin, which is associated with them falling ill due to whatever reason. So bilirubin levels in this condition tend to be actually below 4. So you rarely see high levels of bilirubin in Gilbert syndrome. And Gilbert syndrome is a benign condition. And the main treatment for this is reassurance. So I think it's important to identify this condition, and by identifying this condition, you'll be saving the patient from a lot of unnecessary investigation. The other conjugation defect, which is indirect and inherited, are the Crigler-Najjar syndromes, where there is a complete absence of UDP glucuronidase transferase in type 1, which is the more severe type, which is associated with neonatal jaundice and kernicterus. And the type 2 will have some activity, maybe around less than 10%, but it's more severe than Gilbert's. The bilirubin level is about 6 to 25, and again it fluctuates with the illness, intercurrent illness, and it reduces. This is one condition where phenobarbital may reduce the bilirubin levels and can be used as a diagnostic test where you feel the condition may be present. For both of these conditions, the definitive test, however, is a genetic test. It costs a lot of money, but it can give you the answer. And there's no specific treatment for either condition. Gilbert syndrome is benign, and even Crigler-Najjar type 2 may be benign in adults, and there is no specific treatment or specific risk associated with these conditions. So I think identifying them may help us to reassure the patients, though sometimes it's pretty challenging. The other category is the direct hyperbilirubinemia. This is where the soluble or the conjugated bilirubin is high. So the conditions can be inherited. Most of the times they are the inherited conditions, which are extremely rare though. There's Dubin-Johnson, which is a defect of the multidrug resistance protein MRP2 gene. And then there is Rotor syndrome, which is a defect of organic anion transport polypeptide genes. So both of them lead to problems with uptake and transport of bilirubin. And what happens in these conditions is that there is a higher direct bilirubin. So Dubin-Johnson can be identified by doing a nuclear medicine test where we can look at radio-labeled indole-acetic acid scans, and by about 4 hours, most of the gallbladder should be full, and you should be seeing the bile ducts as well when you do this scan after the administration of labeled HEDA. But the thing is, in Dubin-Johnson, the gallbladder may not be visualized even after 4 hours. So this signifies a defect in the excretion of bilirubin. The other thing is that Dubin-Johnson syndrome. If you do a liver biopsy, you see black pigment, and the livers, when you see them laparoscopically or during laparotomy, are usually pigmented. Again, it's a benign condition, and there is no specific treatment and no specific prognostic problems associated with this condition. There are other causes of isolated hyperbilirubinemia, which may be mixed, maybe either or direct or indirect. And the common things that we see in us being a cardiac institute are with patients with varied forms of cardiac failure. Patients who are on ECMO, extracorporeal membrane oxygenation, tend to have hyperbilirubinemia because of hypertransfusion and also because of hepatic congestion. And there are patients who develop hyperbilirubinemia in sepsis and in a chronic situation with Budd-Chiari syndrome where there may be no other defects in the liver enzymes. The only clue might be hyperbilirubinemia. And then in portosystemic shunts, where there is a shunting of blood from the systemic to the portal shunt, the bilirubin metabolism may not occur because of the shunting, and therefore bilirubin levels may rise. So just as I said, there's an approach for isolated hyperbilirubinemia where the patient has normal imaging, and you look at whether the direct component is less than 15% or more than 15%. And if it is less than 15%, you're going to look down the indirect causes, which include hemolysis, and then you're going to review the drugs, and then you're going to think about inherited disorders. And then if there is more direct bilirubin, often in the Dubin-Johnson rotor, they can be almost as high as 50%. Then you're going to look at the other inherited disorders. So coming to the concept of what we call transaminitis or rise in AST/ALT, also a process called hepatitis. So the terms are used differently. So somebody might use the term transaminitis to signify a patient who is not jaundice, but just as a rise in AST and ALT, and hepatitis may be used as a term where there is jaundice. So you got various causes for hepatitis. So, and the AST/ALT may give you a clue. So if you have a rise in AST/ALT and the patient has an acute viral hepatitis or a toxin like rat poison or paracetamol, the AST/ALT levels rise significantly, more than 25 times upper limit of normal. The other condition where they go up significantly is ischemic hepatitis. So suddenly somebody has a shock after, say, a myocardial event or after a sepsis and collapse. The AST/ALT can again go up significantly in these patients. And that is usually happens within a day of the shock episode. And then the levels start coming down as the patient recovers. The other important things to remember is that when we talk about alcoholic hepatitis, you would assume that the AST/ALT are going to be high, but it's not the case. Usually the AST is less than 8 times upper limit of normal and the ALT is less than 5 times upper limit of normal. So in a predominantly alcoholic hepatitis, the AST/ALT rise may not be that dramatic. And a dramatic rise in somebody who is taking alcohol, you should still look at do they have another etiology for the hepatitis. In people who have NASH, which is the non-alcoholic steatohepatitis due to fatty liver, AST/ALT levels may be chronically raised, and usually they tend to go around less than 4 times upper limit of normal. And in chronic hepatitis B and C, there are certain patterns. So in HCV, normally there is not such a significant rise in ALT and AST. Maximum you might see is more than 10 times upper limit of normal, but most of them tend to be around 2 to 3 times upper limit of normal. So the changes happen in hepatitis B. So the asymptomatic incidentally detected hepatitis B will have a completely normal liver function. And then there are some people who may have mildly elevated ALT of more than 40 to 80. And then there are people who develop what is called a flare, in which the ALT/AST levels just shoot up and they develop jaundice. So, and in an acute hepatitis, which can be hepatitis B as well, where it is newly acquired in an adult, there can be an acute hepatic reaction where the ALT and AST can go up to 25 times. So I think it's important to understand that hepatitis B presents variably with the liver enzymes, and it depends on which stage of the disease and which pattern they are having. According to that, you can direct your investigation and treatment. So just to summarize the raised aminotransferases, the first key thing you do is take a good history. Once you have taken a good history, then there may be things that you can look at, whether there is muscle disorder or whether there is drug-induced liver injury, and you can immediately stop the drug, and at that stage itself, so help the patient to start recovering. Then you can, if the history is unrevealing, then you go on to do what is called a liver screen. So the liver screen is a battery of blood tests that try to look at etiology of the transaminitis. So you're looking at mainly in our context, hepatitis B is extremely common. So you're looking at HBsAg as a screening tool for hepatitis B, but also you can look at anti-HBC total, which can sometimes give you a clue that hepatitis B has happened in the past, even if HBsAg comes back negative. Anti-HCV again is an important initial investigation for people who have transaminitis. In rare situations, you may start looking further at disorders of hemochromatosis by measuring their iron, TIBC, and ferritin. And then you may start looking at autoimmune hepatitis, and this is picked up by ANA, SMA, and hypergamma-globulinemia by protein electrophoresis. So in these cases, you can do a liver biopsy where there is a doubt that there is an autoimmune process. Again, ceruloplasmin in young people may be useful to pick up Wilson's disease, and always do an ultrasound to look for any cholestasis. So it also gives us an idea whether there is cirrhosis of the liver and whether there is any other reasons for rise in liver function tests like malignancy, etc. So if the history is suggestive of steatosis, if the ultrasound is suggestive of steatosis, then you start working them up for fatty liver disease. One of the important things to do is recommend weight loss. And if they have anti-HCV positive, you go on to do an HCV RNA, because there is about 25% of people who are anti-HCV positive but don't have the active infection. So doing an HCV RNA helps you to know, one, whether they have current infection, and two, what the genotype is to direct your treatment. And if they're HBsAg positive, then we go on to look at what stage they're in. And one of the things that we do is HBe antigen and anti-HBe, which helps us to know whether this is a childhood infection or more recent infection sometimes. And an HBV DNA quantification helps us to know whether there are high titers and whether we need to start thinking about treatment. For Wilson's disease, if patients usually have a reduced ceruloplasmin, you do a 24-hour urinary copper. And if that is elevated, then you can do an ophthalmoscopic examination to look for a Kayser-Fleischer ring. And then a liver biopsy measuring the dry weight of liver copper will help you to conclude the diagnosis of Wilson's disease. So there are other things as well, like alpha-1 antitrypsin in somebody who has got COPD and liver disease, thyroid function test, and screening for celiac disease. And sometimes we have somebody who has HCV but don't have the anti-HCV. So HCV RNA may be considered if we are really not sure about what's going on in the preliminary screen. And then ultimately we have got a liver biopsy. So liver biopsy may be indicated in people who have autoimmune liver disease, in fatty liver disease, and hepatitis B and C sometimes. But also in unidentified causes of transaminases, a liver biopsy may give us the answer. And it also gives us the level of fibrosis, and it can help us to prognosticate how they are going to do in the future. So the pathway will be history, followed by certain specific blood tests, followed by further blood tests. If the initial battery of blood tests shows you a pathology, then you go on to deeply evaluate that. And if you are not sure, then go for a liver biopsy. So that is the main approach for a transaminitis. The other part that can happen is cholestasis. Cholestasis is IPAD excretion of bile from the liver. So there is direct hyperbilirubinemia usually in these patients because the conjugation is not the problem is excretion. So cholestasis may happen in the intrahepatic level, or it may be extrahepatic. And when you look at an LFT in somebody who's got a raised alkaline phosphatase, then you may suspect cholestasis. And the key thing is gamma GT is also raised in these patients to give you a clue. So if you see an isolated ALP rise, then you can look at gamma GT and 5-NT levels. And if you find that the gamma GT and 5-NT are normal, it may signify a bone origin. So simple vitamin D deficiency, for instance, osteoporosis, osteopenia, etc., may fractures, Paget's disease, etc., may actually raise the alkaline phosphatase. So you may need to do a bone evaluation rather than go down the route of a liver evaluation. But if you see a raise in gamma GT and 5-NT levels, this is a surrogate marker saying that the source of ALP is liver. So then you can look at a workup where you're looking at the drugs, because the drugs are the most common cause for cholestasis. And then after that, you start looking at other causes like AMA for primary biliary cholangitis, and then sarcoidosis by ACE levels, and then an ultrasound to look for bile duct obstruction. So if you have something that looks like it is a rise in antimitochondrial antibody or ACE level, and you're thinking that it is granulomatous hepatitis, then you can consider a liver biopsy. But then if the ultrasound shows that there's an obstruction in the bile duct, then you may need to go down the route of an ERCP and sometimes doing a CT to see to get more information. But if you're not able to get an answer from either, then you can consider MRCP to look for primary sclerosing cholangitis. So there are certain appearances on the MRCP for primary sclerosing cholangitis, and then you can ultimately consider liver biopsy if there is still a cholestasis and you're stuck and you don't know what's going on. So the methodology for cholestasis is first exclusion of drugs. The second is imaging to exclude large duct obstruction. And then the third thing is consider liver biopsy and further specialized imaging like MRCP, etc. if you don't have an answer. So like I said, the cholestasis can be intrahepatic where the stasis of bile happens at the canalicular level, and the main reason for this is drugs. So something simple that we use like augmentin, flucloxacillin, estrogens, some bodybuilders who use anabolic steroids, non-steroidals, a lot of antiarrhythmics, antiepileptics, etc. are all implicated in cholestasis. So the list is pretty large. So the important thing is to take a drug history and eliminate any of these if you come across them, so that the recovery can be faster. Then there are the granulomatous infections. We see a lot of TB in India. We see sarcoid, brucella and histoplasma are rare, but still need to be thought about if there is a febrile illness or if there are any other clues. Then we have to definitely think about malignancies because these are common, and cholangiocarcinomas, pancreatic malignancies can directly obstruct the bile ducts. But cholangiocarcinomas causing intrahepatic cholestasis usually tend to be intrahepatic cholangiocarcinomas. So in the setting of intrahepatic cholestasis, we are looking more at cholangiocarcinomas, which are in the smaller ducts in the liver, lymphomas which can diffusely infiltrate the liver, and metastasis which can be micrometastasis or even multiple macrometastasis. Then we have the disorders like primary biliary cholangitis and primary sclerosing cholangitis, which are extremely rare, and then infiltrative disorders like amyloid, etc. And then viral hepatitis may have a intrahepatic cholestatic phase as well. And then there are rare disorders called familial intrahepatic cholestasis, primary familial intrahepatic cholestasis, and brain recurrent intrahepatic cholestasis, which are in some way inherited conditions. And then there are also pregnancy-related cholestasis. I mean, people on total parenteral nutrition, they may develop cholestasis during their second week of TPN. And then there are rare things like HIV cholangiopathy and then graft versus host disease in BMT recipients. So the list is pretty exhaustive. So I think you'll have to take a detailed history, a past medical history, drug history, and then try to narrow down the diagnosis. And then for extrahepatic cholestasis, it's just obstruction of the bile duct at various levels. So you're looking at commonest resembling cholelocholithiasis, stones in the CBD, and then cholangiocarcinomas, and then tumors of the ampulla, pancreas, and then pancreatitis patients can develop cirrhosis, which can again cause extrahepatic obstruction, and then other malignancies, and then primary sclerosing cholangitis involving the large ducts as well. So there can also be lymphomas affecting the nodes in the porta hepatis, which can cause large duct compression, which is slightly different to what you see with intrahepatic cholestasis. Management is different for the two. And rarely ascariasis has been described as a cause for extrahepatic cholestasis. So the distinction between intra and extrahepatic cholestasis is sometimes made on the basis of imaging. And again, both these conditions may present similarly with jaundice, pruritus, and the more malignant causes like tumors may present with weight loss, steatorrhea, and so it's important to have a detailed history so that you can narrow down the diagnosis. And then there are other uses for the LFTs. So using the LFTs, you can prognosticate people who have chronic liver disease, and there are a couple of scores that are now commonly used in people with chronic liver disease, and one is MELD score, which is the basis for deciding who needs transplant and for prioritizing need for their liver transplant. And recently, MELD score was was updated by the UNOS using sodium as an additional marker, because sodium hyponatremia is a marker of mortality in patients with liver disease. And this has also come into the calculator from 2016. And MELD uses bilirubin, INR, and creatinine, and more recently sodium. And the problem with the MELD is that it's a very complex calculation, and there are calculators available that you can use on your phone, which can calculate this for you when you put in the values. So there is MD-Calc or MedCalc or many calculators which can do it for you at the bedside. And then the other one is Child-Pugh or the Child-Pugh score, which takes into consideration a few clinical parameters in the form of ascites and encephalopathy, and then looks at albumin, INR, and bilirubin. And again, you got A, B, and C, which are prognostic, which help us to prognosticate the mortality. And then coming to the assessment of liver fibrosis, this is again an evolving field, and there have been a lot of developments in this field over the last decade. So liver fibrosis is the initial stage of developing cirrhosis, and you got multiple stages of liver fibrosis ranging from F0 with no fibrosis to F4 using what is called the METAVIR score. So the older way of doing this assessment was doing a liver biopsy and staining it specifically for fibrosis. But more recently, we are trying to do it in a non-invasive way so that we avoid the risks of a liver biopsy. And the things that we do are a few ratios from simple blood tests that you can do for the patient. So AST-ALT ratio is AST and ALT. It was initially developed in HCV and later has been used in fatty liver disease as well. And then there is AST to platelet ratio. And then there's a score called BARD. And then there are specific panels which are made by certain companies. One is called ELF and one is called Fibrometer and one is called FIB4. These are specific panels which can give an idea of fibrosis. The problem is that these may not be absolutely correct in predicting advanced fibrosis. Most of these tests are useful for excluding fibrosis. So they have a good negative predictive value. So when these scores are within the ranges, then you can say that the patient does not have fibrosis and you may not need to do a liver biopsy or further test. But if these scores are high, then it may need that you will need to do further evaluation. So that may be in the form of imaging. And nowadays with imaging, we have got something called FibroScan, which is a reasonably portable machine, which is a painless test which can be done in an office, and it gives you a reading called the liver stiffness measurement. So based on that, it gives a scale of F0 to F4 fibrosis. And then there have been newer developments like Siemens ultrasound have got something called acoustic radiation frequency imaging, and there is another company, Philips, which has got a machine called point shear wave elastography. Both of these are ultrasound machines which are used for ultrasounds but have an additional software function which can measure the fibrosis in the liver, which is the scarring in the liver. So they are also again having a high negative predictive value, but when they give a higher readings, you may need to follow it up with better tests and sometimes a biopsy. MR elastography again is very limited in terms of availability. It is the most recent test, and a specific machine with a specific module is required for doing this. It's pretty expensive, and availability, like I said, is in a very few centers. So we have got one of these, and we use this for a few cases where we are not sure about what the readings are with FibroScan and the ultrasound-based techniques. Liver biopsy ultimately is the gold standard for fibrosis, and it can help you prognosticate and also manage the patient in the long run. And the important thing is to understand that even liver biopsy can miss fibrosis if the biopsy tract does not pass through the area of interest. So I think there are some limitations as well. And then there are complications like bleeding. There is bile leaks which can happen with liver biopsy. And there have been instances of post-liver biopsy mortality as well. So this is a test which we would do if we don't have an answer from any of the other specific imaging that have now expanded recently. So having said all that, I think we'll just try to discuss a few cases which we have encountered. The first case is a patient who came to clinic. Is a 38-year-old man, and he gives a history of jaundice for 1 month associated with lethargy, anorexia, and feeling generally unwell. He had a significant history of alcohol use disorder for many years, and he just stopped a week before coming to see us. There were no other drugs that he was taking, and there were no other histories, risk factors for before presentation on the history. On examination, he was icteric, and he had a few signs of encephalopathy in the form of flaps, and he had edema, and on abdominal examination, he had ascites and hepatomegaly. So the diagnosis in this case seems to be mainly because of the history pointing towards alcohol. So when we look at his liver function test, there are a few things that can help us to decide that this is probably due to alcohol. And when we see the bilirubin, it's pretty high at 22 with a mixture of direct and indirect, but the predominant fraction seems to be direct. And then you see the liver enzymes. And like I mentioned in the analysis of AST and ALT, this man's liver enzymes haven't gone up much at all, though he's got a very sick liver and he's pretty generally ill because of the alcoholic hepatitis. The AST has just gone up about 3 to 4 times upper limit of normal, and the ALT is just about 1.5 times upper limit of normal. And the alphos and alphos slightly elevated, but the gamma GT is significantly raised, which may be because he was drinking till a week ago. Now, one of the things you can look at is the AST to ALT ratio, and in alcoholic hepatitis, usually it's greater than 2. So most of the people, when you have a jaundice, alcohol history, and very low transaminases, relatively low transaminases like this, if you look at the ALT and the AST is more than 2 times the ALT, it is another way of telling that this patient may have alcoholic hepatitis. The gamma GT is a surrogate marker of alcohol intake in this particular case. So there are also some other clues. The synthetic function is badly affected with both INR and albumin being low. Albumin is 2, which indicates that this problem has been going on for more than 2 to 3 weeks, because as we know, the half-life of albumin is roughly about 2 to 3 weeks. And if the hepatic synthetic function had reduced to 2 weeks ago, it will start reflecting now. And then the INR again is a marker of the synthetic function of the liver, but like we said, there is a rebalanced hemostasis in patients with liver disease. The INR is important in patients with alcoholic hepatitis because it is a prognostic marker. So there is a particular scoring system called a Maddrey discriminant function, which uses bilirubin and INR to arrive at a prognostic score. And there are other scoring systems for alcoholic hepatitis. There are multiple scoring systems, and INR and bilirubin are important components of all of them. So in this particular case, he's going to have a discriminant function of more than 32 because of a very high bilirubin and a high INR. So this gives us mortality at almost 50% at 30 days. So we have done a few things just to make sure he doesn't have any other comorbidities. HbA1c, HCV is negative. The ferritin was high, and again you see this pattern in patients with alcoholic hepatitis. So you may think this is hemochromatosis, but in a lot of patients with alcoholic hepatitis, there is a significant systemic inflammation going on, and the ferritin tends to be raised, and there may also be a low-grade fever in these patients. So it's important to recognize that the hyperferritinemia in these patients may be a part of the inflammatory response and not a diagnosis of hemochromatosis. So I think that is something we see sometimes, and in this particular case, we saw that. And then it's always common to see anemia, and quite often it's macrocytic in these patients. And the reason is that there is a direct effect of alcohol on the bone marrow, causing some marrow suppression. And then there is also deficiencies of B12 and folate in these patients. And also there can be specific conditions. There is a condition called Zeeb syndrome described in alcoholics, where there may be a hemolytic process going on. So, and more immature cells coming out in the circulation. So MCV may be raised due to various reasons. And the total count of being slightly high is also noted. The neutrophilia is also noted in patients with alcoholic hepatitis. And the platelet count is low here, which may signify that there is some element of chronic liver disease. So we may end up having a splenomegaly when we do an ultrasound. So to analyze this LFT, like I said, the bilirubin is pretty high, and the prognostic marker here of the bilirubin and the INR. So the AST level do not matter in a patient with alcoholic hepatitis because they tend to be low. So do not be misled by a normal or a low ALT. in a patient who takes alcohol, because the bilirubin and INR and to some extent the albumin are the main prognostic markers. And again, hyperferritinemia and systemic inflammatory response may be seen in patients with alcoholic hepatitis. So the next case here is a 24-year-old lady who had recently traveled and was eating out in a few hotels and developed a fever approximately a week after returning back. She also had diarrhea for a couple of days and then gradually felt very lethargic and then anorexic, and then she noticed that she was having jaundice. Whole process took about a week. And then there were no history of any drugs, either prescribed OTC or illicit drugs. There was no history of alcohol or complementary medicine intake. And on examination, she was ectric, but there was no stigmata of CLD. The liver edge was just palpable, but there was no stigmata of chronic liver disease. So this pattern is suggestive of an acute jaundice, and in an young person with a recent travel may point out to a pico-oral hepatitic process. So in her, the LFT showed a bilirubin of 10 and a direct bilirubin predominantly. And then the ALT is strikingly high. It is 5,000 and the AST is 3,000. Again, this states that this was a healthy liver that has been suddenly affected by the infection, leading to a lot of the hepatocytes dying, and therefore the ALT levels, transaminase levels have shot up significantly. The important prognostic marker here is INR and encephalopathy. So patients who have an acute viral hepatitis tend to do badly if they develop encephalopathy, what we call a fulminant hepatic failure, or the newer terms are acute liver failure and acute or chronic liver failure and chronic liver failure. So the patients who have viral hepatitis tend to have an acute liver failure, can have an acute liver failure picture, and their prognosis can be pretty poor if that happens. But thankfully, most of the viral hepatitis A and E, which is what I'm referring to here, most of them recover and are self-limited. So it's important to note that the ALT and AST significantly being raised means that the pre-existing condition was that of a healthy liver, and a sudden insult has shot up these enzymes. And then you would tend to see a rapid rise in bilirubin in these patients. And then the enzymes start dropping first, and then the bilirubin follows. So the jaundice may take 4 weeks to resolve in this particular case, but the transaminases may resolve in about 5 to 7 days. So again, INR is a prognostic marker, and the presence of encephalopathy is a prognostic marker. So albumin tends to drop, but usually not to a significant level. And then another illustrative case, this is a patient who we saw in our cardiac ITU, a 27-year-old female who has a long history of cardiac disease with severe mitral stenosis, secondary portal hypertension, and also tricuspid regurgitation. She underwent a mitral valve replacement and tricuspid repair, but it was a very complicated surgery, many hours on cardiopulmonary bypass and subsequently on ventilatory support and inotropic support. Pre-operative serology was negative, and pre-operatively our LFTs showed mild rise in bilirubin, maybe a slight rise in AST, and a slight rise in alkaline phosphatase. But other than that, there was no significant issues. She underwent surgery, and on post-operative day 2, after this difficult surgery, she's on inotropes and on ventilatory support. We suddenly see this picture. The ALT shot up to 1200, AST is 2400, and then the bilirubin is going up, and all the other enzymes are also rising. And the albumin is dropped, which can be an acute phase due to the surgery and blood loss. She had quite a lot of blood loss and transfusion as well, and that could have also contributed to the bilirubin. So this is a picture of somebody who had a liver which we call a prime liver. So probably because of the tricuspid regurgitation, she had hepatic congestion beforehand. And so when she went through a surgery which caused a significant change in the hemodynamics, she just then went on to have an ischemic hit, a second hit to the liver, where the blood supply to the liver went down suddenly. The ultrasound which we did showed a mild hepatomegaly, but the important thing was she had the dilatation of the IVC and the hepatic vein, suggesting that there was still ongoing congestion. So the problem here is that this is a secondary hit to the liver due to the cardiac condition, and most of the treatment in this particular patient is directed towards correcting the cardiac condition. Most of the medicines we give normally do not work. Things like ursodeoxycholic acid has been tried. One of the things that we do sometimes use is N-acetylcysteine, what's called NAC, like we use for paracetamol, to try and bring down the liver enzymes faster. But having said that, the rise in bilirubin is a prognostic marker, and the higher the bilirubin, the worse the prognosis. So in these patients, the bilirubin is a prognostic marker, and we see this often in complicated cardiac surgery patients who undergo a major surgery with long time on cardiopulmonary bypass. So the management is mainly addressing the hemodynamics and correcting the underlying cause. So this patient actually went on to have a prolonged stay in ICU and then eventually recovered. And the LFTs, when she left hospital, she still had a significant hyperbilirubinemia. But fortunately, she did come out of ventilator support and ICU and made a recovery. So there may be transient abnormalities in liver function test after cardiac surgery. We have seen this in patients who want to go bypass where they get ischemic hit. We have seen this in patients who have had cardiopulmonary resuscitation and then have rise in liver function test. So there are multiple reasons. Drugs again, certain drugs like amiodarone can cause an acute liver injury. Some antibiotics can cause that. So ATT can cause that. So a lot of drug-induced liver injury can also present with a similar picture. So I think at this time, I think probably may have run out of time. So I'll just try to conclude here. The main thing is that during this talk, we spoke about the basics of biochemistry, the basics of the liver function test, and try to apply it with the history and the clinical picture to the patient to get a diagnosis and direct management. So I think we have to understand that there are multiple causes, and we are discovering more and more etiologies for liver disease. And the presentations can be a simple asymptomatic patient walking into OPD with just a printout saying that they have an abnormal LFT to varied presentation. So detailed history, identifying the pattern, and then using prognostic scores appropriately, and also assessing fibrosis, which is now the new important tool in managing long-term patients with chronic liver disease. So I think I conclude with that. And if there are any questions, we'll see if we can answer them.
Doctor, this is Dr. Baliga speaking.
Hello.
Yeah, hi. I wanted to ask you one question. In say a 35 or 40-year-old young lady who has no past history of any liver disease, she's not been on any drugs which are hepatotoxic. Say she's to undergo abdominal hysterectomy for fibroid uterus. Is it important to do liver function test as baseline tests?
It depends. I mean, it may not be necessary to do a liver function test in every patient that you would want as a baseline test. Because I think this patient would have already had an ultrasound, I assume, and the liver might have been imaged already, and it may be normal. But if there are any changes in the liver, say they're saying there's a fatty liver or any changes, any gallstones, then it may be appropriate to do them. But as a pre-op evaluation, unless it's going to be a complex cardiac surgery or somewhere where you're expecting problems in the post-op period, for what you think will be a relatively straightforward surgery with less blood loss, it may be more important to do their serologies to make sure they don't have any occult viral infections rather than liver panel. But obviously there are many anesthetists, and quite a lot of the pre-op panels nowadays require a liver function test. So quite often it may not be mandatory, but you know, if you develop, if the patient develops an abnormality later on, say they go into shock due to bleeding surgery or some other sepsis, and then you suddenly see an abnormality, then you wouldn't know whether that was pre-existing or whether it is whether it was a baseline, what was the baseline like. So may be useful if you are anticipating complicated surgery, difficult recovery, to have a baseline so that you know things are normal, and if things deviate, then you know that you have done your bit in identifying problems beforehand.
Okay, thank you. Because some patients are very intelligent. They read up a lot and come, and they do ask, what's the necessity for this?
Yeah.
So, and in the same vein, I want to ask you, in these executive health checks, you know, normal people going for this health check, say she's a 30-year-old lady. Is it important to do these LFTs and scanning of the liver? Because mild fatty liver and so common.
Yeah, I mean, the thing is, one of the commonest referrals we get to gastroenterology clinic nowadays is from the executive health check. These are totally asymptomatic patients who walk in with a ALT of 70 or 80 from an executive health check.
Huh.
And quite often they may be obese, they may have lifestyle issues, and it may be useful to start counseling them at that stage where they can make a modification, because for fatty liver we don't have any treatment that works as it. So most of the treatment is directed towards lifestyle modification, exercise, weight reduction, etc. And so identifying that early in somebody who wants in a well woman who wants to know if there is any pathology may be reasonable. So if you identify a fatty liver early, you counsel them, and then you identify any risk factors, and then you start acting on that, you may modify their further future course. So sometimes there may be dyslipidemia, which may be familial, which may be picked up as a base on the basis of a fatty liver. And sometimes there may be occult hepatitis B. Very rarely we have picked up hepatitis B and C from a health check where the transaminases were high. So there are some things, but again, it's a patient's choice. Nowadays patients say they want to go to full body check, they want a liver check and all that, and end up getting these tests, and quite often they have a insignificant raise with a normal liver on ultrasound, and you don't know what to do. Quite often you don't know whether you should be classifying them as fatty liver when the liver looks normal, or whether you should be following them up intensively. So quite often it causes a diagnostic problem for us, and sometimes it is not it is not worth the hassle. But certainly you can do some lifestyle modification early for fatty liver, which can definitely change their outcomes later on in life. Are there any other questions? So just I think there were some questions about itraconazole and how do we monitor LFT 8 to 12 weeks. I mean, it's difficult because I think you do a baseline LFT. This is another common referral we get from dermatology, and quite often we do a baseline LFT and it's abnormal, and there is no right or wrong answer. The basic thing is to make sure there is no underlying liver disease. So we generally ask them to we do a detailed history, drugs beforehand, because they may have been on something before giving itraconazole. We do a detailed history beforehand, and then maybe in some cases do an ultrasound to look for fatty liver or any other risk for liver disease, and very rarely, if there is high risk behavior, ask for hepatitis B and C. But there is no right answer on how to monitor. Quite often it depends on the extent of transaminase. If it is very high, I wouldn't give the drug. If it is mild rise within less than two times upper limit of normal, we may give the drug and then recheck again ALT and AST after a week and see how they are doing. It's a clear counseling that they should stop if they're getting any symptoms like nausea, abdominal pain, vomiting, and if they're noticing any discoloration of the urine or any symptoms of jaundice. So I think there's no recommendation for where you should withhold, but generally common sense is that we advise people who have got more than 2 times upper limit of normal of LFTs to go for some tests to see if there's any underlying disorder before we ask them to take the drug. And then there is methotrexate. There's a question about methotrexate and liver biopsy. Again, the methotrexate is the cumulative dose, and it's correctly mentioned in the question that when we exceed 1.5 grams. So it is not, there may be rare case of idiosyncratic drug-induced liver injury from methotrexate, but the vast majority of methotrexate related complications tends to be delayed fibrosis. There have been some procollagen 3 peptide P3 and P, which is a blood test that's been used by rheumatologists to monitor patients for methotrexate. And when these levels are raised, then we go on to image them with ultrasound and fibroscans. And if there is a doubt, ultimately do a liver biopsy. But then the P3 and P is not widely available, and sometimes it may be worth, after reaching a cumulative dose of 1.5 grams, to start doing fibroscans maybe every 6 monthly and LFTs to see if there is any changes happening. And then if there are changes, then look at whether to discontinue the drug and look at other options. And again, another question about itraconazole, which we have answered. And is there any pattern for ATT-induced hepatitis? I mean, ATT is like a chameleon. So there are varied patterns. We have seen patients with just hyperbilirubinemia. We have seen patients with florid hepatitis, which happens within the first to second week of starting ATT, where the AST levels first go up. Patient usually feels sick by this time. They get nausea, they can't tolerate the drug, and when you do the LFTS, you see a significant rise in AST and AHT. And then there is jaundice in these patients. There are some patients who present with jaundice alone. And then there are patients who present with cholestasis due to rifampicin. And then there are patients who have pre-existing chronic liver disease who go on ATT, which is not recognized. And then suddenly you see them develop a hyperbilirubinemia, and then the enzymes may not go up that much because the liver is already damaged. So there is a wide spectrum, and quite often what we need to do is stop the drug and then look at the patterns of recovery, and then do a gradual reintroduction. Depending on which drug, which is predominant, you may want to leave out the pyrazinamide if it is hepatic pattern followed by INH. So the pyrazinamide and INH are the two main reasons for an acute hepatic reaction in ATT. So you may want to do regimes which exclude these two, and then look at a gradual reintroduction of INH. Sometimes if it is a predominantly cholestatic pattern, you may have to do the same with rifampicin. So again, it depends on the individual case, depends on how good the liver is on ultrasound, and are there any other reasons for the rise in LFTs. So I think we'll conclude here. Are there any further questions?
Thank you, Rangarajan sir, for this wonderful class.
Sir, you're muted, sir.